Welcome to Module 10. I'm Dr. Greg Meyer, the Senior Vice President for Quality and Safety at the Massachusetts General Hospital and Massachusetts General Physicians Organization, and also the Chairman of the Board of Governors of the National Patient Safety Foundation. And I'd like to thank you for taking the time to go through our curriculum. Module 10 is on the national landscape, policy, regulation, and the environment. We'll be moving through slides as part of this presentation, which will accompany this audio portion of the curriculum. Slide number 2 lists the objective for this program. In Module 10, the National Landscape, Policy, Regulation, and the Environment, we intend to cover the external influences in the field of patient safety by exploring new and emerging trends in healthcare policy at the federal, state, and local level. Participants will learn the functions of external agencies and regulatory bodies, be able to discuss effective strategies for meeting reporting requirements, and learn techniques for optimizing operational systems and processes to assure compliance with industry standards, such as the National Patient Safety Goals and accreditation requirements. Slide 3 shows you the goals of this module. Upon completion of this module, participants will be able to explain the role of external agencies, regulators, and standard-setting bodies in the field of patient safety. They should also be able to summarize current healthcare policies and initiatives and describe their impact on clinical practice. And finally, be able to design and implement processes to meet national patient safety goals and comply with other industry standards and guidelines. Our goal upon the completion of this module is for you to feel confident that you understand the landscape governing patient safety and that you feel well prepared to meet the challenges of compliance and regulatory requirements. In Slide 4, we begin our discussion of the regulatory and policy context. Slide 5 shows you a picture of Ernest Amory Codman, a physician at the Massachusetts General Hospital who early in the 20th century recognized that hospitals ought to be held to a higher standard than that of the day. In particular, he suggested that they rely on an end result system where outcomes are both collected and shared publicly. The cartoon on this slide was created at the behest of Dr. Ernest Amory Codman to promote Codman's end result system, and it was first presented to the Suffolk District Medical Society in January 1915 in Boston. Codman, a chairman of the surgical section, surreptitiously arranged to use the meeting to expose the hypocrisy he saw behind resistance to his reforms. It depicts the president of Harvard standing on a bridge from Cambridge, wondering whether it would be possible for the professors of the medical school to support themselves on their salaries if they had no opportunity to practice among the rich people of the Back Bay of Boston. The Back Bay is represented as an ostrich with its head in a pile of sand, devouring humbugs and kicking out her golden eggs blindly to the professors who show more interest in the golden eggs than they do in the medical science. On the right is the Massachusetts General Hospital with its Board of Trustees deliberating as to whether, if they really used the end result system and let the Back Bay know how many mistakes they made on the hospital patients that were cared for there, it would still be willing to give its golden eggs to support the hospital and would still employ the members of their staff and thus save the expense of their salaries. Armies of medical students on their way to Harvard were seen crossing the river, having heard the end result system would be installed in her affiliated hospitals. In the end, the end result idea and its byproducts began the medical outcomes movement in the United States. It also led to the creation of the Joint Commission, and really has served as the very backbone of the policy designed to standardize hospitals in the United States and to protect our patients. Slide 6 depicts two more recent calls for the equivalent of an end result system. The first was the Errors Human Report from the Institute of Medicine, which called attention to the whole issue of medical error and how we needed a systems approach to combat it. The second was Crossing the Quality Chasm, a more comprehensive report released in 2001, which told us that between the healthcare that we deliver every day and the healthcare that we ought to be able to deliver, there is no longer just a gap, but it is in fact a chasm. These two reports have something very important in common, and as they both educate us to understand that the approach to improving healthcare is not through working harder, but it's through putting systems in place to ensure that our hard work, in fact, benefits the patients that we serve. Taken together, these two reports have really formed the basis on which the American public currently views the healthcare system. That is, that it is not delivering the results that would be expected, particularly in light of the investment that's being made. On slide 7, you can see some of the reaction in the popular press to these reports and growing disclosure about the fact that sometimes Americans do not get the care they ought to get in our healthcare system. These have often been sensationalized, but the truth of the matter is that they do reveal an underlying truth, and that is that healthcare isn't as good as it ought to be, and in many ways it leads to calls for more policy and regulation to help govern the care that's being provided in American healthcare institutions. Slide 8 depicts one of the facts of American healthcare today that again has a profound influence on policy and regulation. That is that there is wide variation in healthcare. In fact, some have argued that if you wanted to predict what type of healthcare would be delivered in any particular area of the country, that the best predictor isn't the patients, it's not the diseases they carry, nor is it their demographics, it's their location. The work of Jack Wimberg and his colleagues producing the Dartmouth Atlas have shown many illustrations of this phenomenon. The one depicted here shows the amount of money that's spent during care during the last 2 years of life for patients around the country, and you can see that some parts of the country, such as New York and California, spend a lot more on those last 2 years than other areas of the country, such as Minnesota, yet the outcomes in all are the same. This was highlighted in an article by Atul Gawande in 2009 called The Cost Conundrum, which was printed in the New Yorker. The illustration for that, showing a patient as an ATM machine which doctors could visit to extract cash for the services they provided, was in many ways quite provocative, but did provide a clear message to the American public. There's clearly an imbalance between the cost of health care and the quality that's being provided. On slide 9, you can see the other aspect that is really driving policy and regulation today in America, and that is that what we are spending on health care is clearly unsustainable. Here you can see the per capita growth in health care costs and how they've grown over the last 40 years, outpacing general inflation by about 2.5% on average. In addition, we know that Americans are spending more out of pocket and having more taken from their wages each year paying for health care. On slide 10, you can bring these two aspects together to really give you a great measure of where the American public's temperature is right now in terms of their views on health care. On the left side, you can see a plot of the relationship of healthcare quality and costs. Contrary to what many would think with many other sectors of the American economy, that there is clearly not the usual if you pay more, you get more relationship illustrated here. In fact, when we array the 50 states plus the District of Columbia in terms of healthcare quality on the vertical axis, with 1 being the best and 51 being the worst, and then look at per capita healthcare costs, you can see that rather than having the usual expected relationship of spending more and getting higher quality, in fact, it appears that the exact opposite is true. Another illustration of this, which is much more accessible, is, and it comes from a Boston Globe front page from several years ago, but is a phenomenon that can be found in almost any American city. And that is that on the top, we see an article about how healthcare isn't quite as good as it ought to be, even at a wonderful institution like the Children's Hospital of Boston. And right below that, we read that fewer Americans are getting workplace health plans because their employers can't afford the premiums. This clash between quality and cost, quality not being as good as it ought to be, and costs being much higher than they ought to be, has led to increased focus on the regulatory aspects of healthcare in the United States. On slide 11, you can see some of the players that are currently asking for more transparency and accountability about how we're doing in healthcare. Those include groups such as the Joint Commission, the National Surgical Quality Improvement Project, the Agency for Healthcare Research and Quality, the Leapfrog Group, and the Center for Medicare and Medicaid Services. Other groups that are asking for data include U.S. News & World Report and the National Quality Forum. And here you can see that healthcare workers are being besieged by a number of metrics. On slide 12, you'll see that that's not all that they're facing. In fact, at the regional level, national insurers, groups such as commercial website vendors, and regional publications are also asking for more transparency and accountability. On slide 13, you can see some of the groups that at the state level, such as the Departments of Public Health, Boards of Registration in Medicine and Nursing, insurance groups, and others are asking for data. And on slide 14, you can see that payers are again asking for more data on pay-for-performance, data for their websites, and data to create tiered networks. Slide 15, you can see that many of our organizations are in addition asking for data for aspects of healthcare quality such as credentialing, creating dashboards, and incentive programs. On slide 16, you can see the way this feels. In fact, most healthcare providers feel quite squeezed in the middle and besieged by the number of individuals who are asking for data. But the reality is they're asking for it because of the phenomenon that we just showed before. People are not getting what they're expecting, and they're asking more from healthcare. With that as background and context, on slide 17, we move into the regulatory landscape. Slide 18 lists a number of the agencies which help form the regulatory landscape for patient safety. They include the Center for Medicare and Medicaid Services, the Joint Commission, State Departments of Public Health, the Centers for Disease Control and Prevention, the Food and Drug Administration, but other groups also play a role, such as the Office of Civil Rights, which oversees the application of HIPAA, and the Occupational Safety and Health Administration. In addition, there are a number of voluntary reviews which many of us participate in, such as magnet surveys by the American Nurse Credentialing Center. On slide 19, you can see one example of 1 year of potential regulatory visits for an institution. These include a visit from the Department of Mental Health to look at inpatient psych unit licensure. Those are done on a 2-year basis. A Department of Public Health random survey on infection control. A visit from the Joint Commission to look at a particular program, in this case, the Ventricular Assist Device program. The Food and Drug Administration, which will look at the blood bank. Department of Public Health Bureau of Substance Abuse Services, which will look at substance abuse clinics and occupational site visits. A Department of Public Health visit on the end-stage renal disease program. A Department of Public Health visit looking at radiation control. A visit from the American Association of Blood Banks, and a visit from the American College of Pathologists. These are in addition to the regularly scheduled visits from the Joint Commission and Department of Public Health. This shows you that it is indeed a complex regulatory landscape with which we must contend. It's somewhat natural for us to bristle at the regulatory burden that's imposed, but on slide 20, we're reminded that there are important rightful roles of regulatory agencies. In fact, one of the things that we challenge you to do is to change the tenor of those conversations. Instead of feeling victimized by regulators, recognize that they have an important role in protecting the public. And in fact, your role as a leader in patient safety is to help ensure that your organization not only meets those requirements, but you have an opportunity to show regulators the great job that you're doing on patient safety. It's important to recognize as well that sometimes the recommendations can be conflicting. An example here would be the Office for Civil Rights, through enforcing HIPAA, can inhibit our ability to be transparent and show all the data that we think that we would like to demonstrate our quality and safety. One of our complex roles is to sort out and sort through those conflicting regulations and conflicting mandates. Those often happen in real time during regulatory visits and will test your expertise as a patient safety leader. It is our hope that through taking this course that you'll feel comfortable navigating these sometimes quite difficult waters. Slide 21 depicts an oversimplified example of the regulatory food chain. In the world of regulation, the big fish indeed is often the Center for Medicare and Medicaid Services. Departments of Public Health often do their work for them and conduct many of the site visits, and the Joint Commission also reports back to the Center for Medicare and Medicaid Services, which gives deeming authority to the Joint Commission to allow organizations to be paid for their health care through federal fundings via CMS. You are swimming in those waters, and all of those fish indeed can at times feel like they're out there to bite you. But the truth of the matter is that they have a role, and you need to recognize their role, embrace it, and use it as an opportunity for you to move your quality and safety agenda forward. On slide 22, you will see the rules that govern the approach of the Center for Medicare and Medicaid Services, the biggest fish in the regulatory sea, as they try to evaluate health care. They do this through their conditions of participation. Those conditions of participation, the 23 of them, are listed here. They include everything from compliance with federal, state, and local laws all the way through to conditions of participation regarding radiology services, laboratory services, organ, tissue, and eye procurement, emergency services, and specific departments such as respiratory care services. These conditions of participation form the grounding for any CMS site visit, and you will be measured against these conditions. With that said, they are quite old and in fact have last been fully updated back in 1987. These are currently undergoing review, and a future update may be released in 2011 or in 2012. On slide 23, you can see that there are two ways that you can be evaluated to be found deficient in terms of meeting the conditions of participation from CMS. The first are condition level findings. That is where you are failing to meet the basic needs as outlined under one of the specific conditions, such as patients' rights or medical staff. If you have a condition level finding on a CMS visit, they will ask you to put together a corrective action plan, and they will come back and revisit the organization to ensure that that action plan has indeed been implemented and has produced the results expected. There is a special flavor of condition level findings which you must pay particular attention to, and that is if during a CMS survey they feel that patients are in an immediate jeopardy situation. This means that they feel that the conditions are not only not being met, but in fact, at that particular moment, because of the failure to meet that condition, patients are in harm's way. If that is the case, CMS will ask you to correct that finding immediately while they remain on site. This, in fact, is the biggest stick that CMS has in terms of changing the care that we provide immediately, and it's an important one because it is an illustration of how they can step in and have regulatory tools to ensure that patients will be kept safe. Below condition level findings are standard level findings. That is where particular standards embedded under those conditions are not being met. These often require a corrective action plan as well, but often do not require a repeat site visit. These are lower level findings and of less jeopardy to patients. Nevertheless, they do require your attention and correction. On slide 24, we begin the discussion of the most important regulatory player in patient safety in the United States at the present time, and that is the Joint Commission. On slide 25, you can see the various influences on the Joint Commission survey process. These include governmental agencies, which are often calling for the Joint Commission to take a harder look at health care, consumer groups, which often have demands to ensure that patients are getting the safe care that's expected, and watchdog groups, which often call to question whether or not the Joint Commission is being tough enough. At the same time, you have the interplay with healthcare organizations, which are often trying to lobby the Joint Commission to take a more soft approach to their survey process to ensure that they are being cognizant of the many challenges that those organizations face. The result of this complex dynamic is a constant evolution in the Joint Commission, which has been managed incredibly well over the last decade to produce a survey process which is not only providing an opportunity to evaluate whether or not we are providing safe care and doing so through the appropriate policies and procedures, but more importantly, to help us learn from the survey process to improve the care and safety that we afford our patients. Slide 26 illustrates the evolution of Joint Commission surveys. This is not your grandfather's Joint Commission. That transformation can be traced back to the beginning of this decade, and in many ways is a response to the Institute of Medicine reports we talked about earlier. This began with the New Pathways program, which created a shared vision of safe, high-quality care. Part of the implementation of that New Pathways has resulted into new approaches to the accreditation process. That includes providing more customized surveys for various care settings, implementing the tracer methodology, which we'll speak about further, moving from regularly scheduled surveys, where the schedule is known years in advance, to unannounced surveys in 2006. The integration of periodic performance reviews, where the Joint Commission asks us to look at our own organizations to evaluate our vulnerabilities and share them with the Joint Commission so that they can become part of the focus of the Joint Commission survey process. They went further to reorganize standards in 2009, which included a new approach to both the scoring and decision process about accreditation. In many ways, you can sum up this transition from a focus in the past strictly on medical care to looking at multidisciplinary care and to looking at it not through the lens of how we respond after we ramp up to get ready for a survey to what kind of care we're providing every single day for our patients. Slide 27 illustrates some of the aspects of the customized survey process. These include a focus on priority focus areas. These are looking at various clinical service groups and also collecting data through the ORIC system to examine particular areas such as heart failure, heart attack care, and pneumonia. Many of the strides that the Joint Commission has helped us make in improving healthcare quality can be traced back to the fact that they've become much more data-driven rather than survey observation-driven over the last several years. They also ask us to look at sentinel event data, those cases where something went egregiously wrong in the care of a patient, such as a wrong site surgery, and will ask you what you're doing to ensure that does not happen in your institution. The past is prologue, and the Joint Commission will look at prior survey findings to ensure that you've improved in those areas. And they will also take a close look at patient complaints. As a result, what was a very generic process in the past has become quite customized to individual organizations. So you need to pay attention to not only your data, but your past history with the Joint Commission to ensure that you will have a smooth survey process. The Joint Commission will use this information to help determine the length and the intensity and duration of the survey process. On slide 28, we begin a review of the tracer methodology. This indeed is the cornerstone of the Joint Commission survey process. Rather than coming into a hospital or healthcare organization and looking at charts randomly, surveyors now follow the experience of care for particular patients throughout the hospitalization or healthcare experience. They evaluate the processes of care through record review, staff interviews, patient interviews, and observations, and then they compare that care with their own standards and the national patient safety goals. Slide 29 shows you how this works in practice. Here we have a patient who came in from home and had some pre-hospital care. The Joint Commission then will follow that patient throughout their hospitalization from the emergency room, transfer to the intensive care unit, then on to the operating room, then being held in a post-operative area or interventional area, transferred to a general unit, and then finally transferred to home. On slide 30, we can see an illustration of all of the different departments that will be looked at through that patient's traced experience. They include everything from transport to chaplaincy to interpreter services, pharmacy, physical therapy, occupational therapy, transfusions, case management, and others. As a result, the tracer method provides a very efficient and real way to be able to assess patients, as illustrated in slide 31. There they can look at patient safety throughout the patient's stay, infection control, communications, assessment and care services, staffing and credentialing. This unique approach allows the Joint Commission to take a very comprehensive view, but in a patient-centered, very real way. It also means that you need to pay great attention to all aspects of a patient's care. We can no longer rely on a surveyor not picking up on particular aspects of a patient care, because the tracer process efficiently and effectively has the surveyor reach into all aspects of the care that we provide. On slide 32, you can see an illustration. Here, a 37-year-old male with a history of substance abuse is in a motor vehicle accident. As they trace that patient through, they will look at the emergency room, the surgical intensive care unit, the operating room, and perhaps a general surgical floor. In so doing, they'll take a very deep dive into looking at nursing services, physical therapy, social work, how the pharmacy is functioning, the lab and diagnostic services, case management, and in this particular case, addiction services. You can see from this illustration that in many ways it's random what type of patient the Joint Commission will pick, but because of that and the efficiency of the tracer model, we need to make sure that we're prepared across the board. So areas that may not get our usual level of attention, such as our addiction services, in fact, need to be fully compliant with the Joint Commission's standards and their national patient safety goals to ensure that we are ready for that survey. On slide 33, you can see an example of what a day with the Joint Commission might look like. This is an unannounced survey, and this shows you day one. The surveyors arrive in the morning, and at that point in time, they do some planning about how they want to help schedule their visit. Then we'll ask for an opening conference and orientation to the organization. Then they will have further planning sessions and begin their tracer activities, and they will follow them throughout the day, going wherever the patient may take them. They then will spend some time later in the day looking at very special issues, for example, things that they may have encountered in laboratory services or in patient identification, and then they will plan the next day. This process goes on for a duration that's determined by the complexity and size of a particular organization. On slide 34, you see some of the reporting and responses that can come from the Joint Commission. At the conclusion of a survey visit, you can expect to have a summary of survey findings to be shared with you and left on site after the survey. Several weeks later, an official survey report will be posted on the organization's secure extranet site that the Joint Commission provides for you, and it will also tell you your potential accreditation status. They will then ask for a response. For example, in this case, there was some findings that pain assessment and reassessment were not as complete as possible. The Joint Commission will ask you to respond to show you that you have the policies and procedures simplified and improved, that in this case initial pain assessment was added to a nursing data set, that the procedure now follows and allows for pain assessment and reassessment to be documented, that flow sheets have been modified, that pilots have been initiated to show that this indeed will work, and that the nursing staff has attended a pain relief course to ensure that they are compliant with that finding. This is an interactive process which takes place over weeks to months following the survey, but ensures that the survey not only provides an assessment, but also provides an opportunity for learning. On slide 35, we transition to what is the most germane aspect of the Joint Commission's work as it pertains to patient safety, and that is the National Patient Safety Goals. On slide 36, you'll see the background on the National Patient Safety Goals. They were established in 2002 and became effective in 2003 to address specific areas of concern in regards to patient safety. The notion here is that we ought to set national standards on what we are doing in every healthcare organization in America to ensure that patients are getting safe care. The Joint Commission mission is to continually improve the safety and quality of care delivered to the public through the provision of healthcare accreditation, and the National Patient Safety Goals are an important lever for them to use in that process. The National Patient Safety Goals have related specific requirements for improving the safety of patients in healthcare organizations to specific actions that ought to be taken by those organizations. The Joint Commission requires accredited healthcare organizations to implement the National Patient Safety Goals as appropriate to the services provided by that particular organization. All accredited healthcare organizations such as hospitals, assisted living, home care, behavioral health care, disease-specific care, ambulatory care, laboratory care, and others are surveyed to evaluate the implementation of these goals as they relate to the services of the organization. On slide 37, we list the 6 national patient safety goals that are currently in place for hospitals. In addition to those 6 goals, they are accompanied by the university protocol to help ensure that we provide surgery safely. We'll spend some time on each of these individually. There have been some revisions in 2011. Those include revised elements of performance, which are specific elements below each of the national patient safety goals to help ensure that an organization is being compliant. The revised elements of performance are effective immediately. There's also been a great deal of discussion on National Patient Safety Goal number 8. This is the one that focuses on medication reconciliation. Here it is important to note that there is no backing down from the importance of medication reconciliation as a cornerstone of providing safe care for patients. With that said, there have been numerous challenges in the field in trying to evaluate medication reconciliation and also in trying to implement it. As a result of that, the Joint Commission continues to do additional work on this particular national patient safety goal. In addition, it's important to note that previously, goal number 14, the goal of preventing healthcare-associated pressure ulcers, has now become a standard for the Joint Commission, so you will still be measured against it, but not as part of the national patient safety goals. In addition, goal number 9, the goal of reducing patient harm resulting from falls, has also become a standard. On slide 38, you can see the current national patient safety goals for hospitals. The first of these includes improving the accuracy of patient identification. The notion that we ought to use at least 2 patient identifiers when providing care and treatment for all services. Embedded within that is also eliminating transfusion errors related to patient misidentification, which is one particular aspect of the overall goal of ensuring accuracy of patient identification. Goal number 2 is to improve the effectiveness of communication among caregivers. We all recognize that communication breakdowns put our patients in jeopardy. Here, the focus is on reporting critical results of tests and diagnostic procedures on a timely basis to ensure that caregivers who can make a difference in the care of their patients are aware of the results in a timely fashion and take appropriate action. National Patient Safety Goal number 3 focuses on the important area of improving the safety of using medications. This includes elements to ensure that all medications and medication containers and other solutions on and off the sterile field in perioperative and other procedural settings are appropriately labeled. In addition, there's a special focus on trying to reduce the harm of one of our most dangerous class of medications, anticoagulants. They also include the need to maintain and communicate accurate patient medication information. This has just become effective in the summer of 2011. Goal number 7 is to reduce the risk of healthcare-associated infections. This includes implementing evidence-based practices to prevent healthcare-associated infections due to multiple drug-resistant organisms, such as vancomycin-resistant Enterococcus, methicillin-resistant Staph aureus, and C. difficile. In addition to that, you need to implement best practices or evidence-based guidelines to prevent central line-associated bloodstream infections. And finally, to implement best practices for preventing surgical site infections. Goal number 15 is that the organization identifies safety risks inherent in its patient population. There, the particular focus is on identifying individuals at risk of suicide and taking appropriate precautions. In addition to that, there is the Universal Protocol, which is a supplement to the National Patient Safety Goals. The Universal Protocol asks that we conduct a pre-procedure verification process, we mark procedure sites, and we perform a timeout with all members of the team participating to ensure that we do the right surgery on the right patient in the right location. On slide 39, we look at goal number 8, reconciling medications. As noted before, this continues to be an important focus for patient safety, although you will not be surveyed against these particular elements at this point in time, but this is expected to change in the future. In terms of reconciling medications, the request is that we accurately and completely reconcile medications across the continuum of care. That means every time a patient makes a transition from home to the emergency room to the floor to the ICU back to a rehab facility, and the rehab facility back to home again. That includes comparing current and newly ordered medications, communicating medications to the next provider, providing an accurate reconciled medication list to the patient and their family, and in settings where medications are used minimally or prescribed for a short duration, modified medication reconciliation may be used, but is still important to ensure that patients receive their medications in a safe fashion. It is clearly recognized by the Joint Commission and all patient safety authorities that reconciling medications is an important safety goal, particularly in terms of reducing readmissions and decreasing the harm associated with improper medication use by patients. On slide 40, we see the particular aspects of the Universal Protocol. The aim of the Universal Protocol is to prevent wrong site surgery, wrong procedures being performed on a patient, and wrong person surgery. And these 3 steps are essential. All 3 steps will be evaluated in detail during a Joint Commission survey. On slide 41, we transition to the final section, which is how do you manage the regulatory process? You have seen that there's a complex landscape out there that has created a reasonable and important interest in ensuring that we are providing safe care, and we need to demonstrate that during those regulatory visits. One can get overwhelmed by trying to create a specific response an action plan for each of the different types of visitors that can come through your door. But the reality is that we need to take a more general approach to regulatory readiness to ensure that we are ready for whoever might walk through the door tomorrow. On slide 42, we review some of the basics of managing regulatory visits. It's important for you to recognize that through the expertise that you gain here in taking this course and your role in your organization, you're going to play a central role in managing regulatory visits. This is an incredibly challenging role because healthcare organization regulatory visits are numerous, they're varied in their scope and depth, and they often come unannounced. It's important for you to recognize that there are 4 steps to that regulatory visit cycle. The first is to be prepared for the next survey. The next is to oversee the survey while you're in the midst of it. Then, when the survey is complete, to develop necessary plans of correction, and then monitor compliances with that plan to ensure that, again, you are ready for the next survey. Doing a good job of managing this cycle, which is illustrated on slide 43, will result in successful surveys, a stronger safety program, and better care for your patients. Slide 44 provides an illustration of how you can organize your regulatory efforts. Here it's suggested that you put together an organizational coordinating committee to ensure your regulatory readiness. This should rely on a careful review of all the requirements from the major players in your regulatory landscape. These include the Centers for Medicare and Medicaid Services, Departments of Public Health, the Joint Commission, your own serious events and your responses to them, work of outside consultants who can come into your organization and do an audit of your patient safety and healthcare quality processes, and also the buzz within your organization. The discussions that take place among caregivers about what they're worried about, what's keeping them up at night, and what they think we ought to be working harder on. By listening to all of those signals, you can set up a set of priorities that are going to ensure that you're successful during your survey preparation. On slide 45, essential aspects of that preparation are listed. They include developing a regulatory readiness calendar to display all known regulatory visits anticipated in the near future. The reality of this is that calendar will never be perfect because of unannounced surveys. You need to share that calendar with leadership and other groups that need to know. You should not be worrying alone about the survey process. In fact, you should be working with others throughout the survey management cycle. Surprises are never good, although sometimes they are unavoidable. And the truth of the matter is that we often learn a lot when we're not particularly prepared for the surveyor to walk through the door, because it tells us what type of care we're providing on an everyday basis. Even if you are surprised, one of the most important things is to try not to act it. Restrain yourself from predicting when regulators will arrive. That game will take you off of the essential focus. On slide 46, we go through some instructions for when regulators and surveyors arrive at your door. For example, you should know that the front desk has been alerted, that there's a notification system so that department leaders and organizational leaderships can be notified of the survey through a pre-established group page or other mechanism. You need to know where your opening meeting will take place, who will attend, what type of materials will be presented. You should also have plans for who will escort the regulators during their visit, and what tools the escorts may need. In particular, what type of data will they want to have access to, and what documents are they going to request. You should ensure that you have suitable workspace available for regulators, and make sure that you verify the regulator identity and agencies and have visitor badges created. Finally, make sure that you assemble leadership and bring the regulators to an opening meeting. This, in many ways, will set the tone. As Mary Poppins has said, well begun is half done, and a very good opening meeting can go a long way to setting a proper tone throughout a regulatory visit. Slide 47 includes some general advice about those opening meetings. Most regulators plan to have a formal opening meeting, and even if they don't, you should insist on an opening meeting with them to make sure that you understand the scope of their visit and how you can be supportive. Most importantly is be proud to tell your story. That regulators want to hear all of the good things you're doing, not just the fact that you're meeting the standards that they set. Discuss your plans to provide escorts to the regulators throughout their visit, and ask the regulators to commit to informal daily debriefs so that such debriefs allow you to rapidly identify areas where you need to do more work and can be better prepared for the next day of the survey. On slide 48, there are some general recommendations regarding survey escorts. You will be served best by putting together an experienced team of people who can accompany the surveyors as they travel throughout your facility. In fact, having senior level leaders within your organization accompany surveyors shows you how seriously you are taking the process. Select and carefully match these escorts with the particular regulators. For example, have a leader in pharmacy accompany that surveyor who's going to focus on the pharmacy, or someone from the pathology department to work with those who are focusing on laboratory services. You should coach your escorts prior to the survey to make sure that they're able to provide the regulators with the policies that they'll need, to keep track of all the patient records that will be reviewed, and get any feedback of any known issues to a central command post. Slide 49 speaks about that central command post. A large-scale survey often needs a group of people who can respond on an ad hoc, as-needed basis to any findings that come up during the survey. We suggest that you pull together a team of staff to help manage events as they unfold during the survey process. That command group serves several purposes, including providing a resource for escorts to call or email when they have problems or they have a request for documentation. It also provides a means to track issues as they arise and quickly develop responses and strategies. These often allow you to respond to particular findings while the surveyors remain on site. And they also provide a communication group to keep leadership and staff informed as the regulatory survey progresses. Plan your command center to have sufficient resources sized to the survey. One of the things that your command center should help you do is prepare for daily debriefs, as noted in slide 50. These are informal end-of-the-day discussions with the regulatory team to give you insight into where they think your problems lie. These often provide opportunities for on-site corrections. They also provide you an opportunity to help correct any regulator misperceptions and discuss your organization's efforts to improve performance in particular areas where they find deficiencies. Even if you have no external debriefs with the surveyors, you should have internal daily debriefs immediately following the end of the survey day with all of your escorts to ensure that you're doing everything that you can do to put your best foot forward. On slide 51, we talk about the end of the survey process, and that is the exit conference. At the exit conference, you'll hear a preliminary report on deficiencies the regulators are likely to assess. There it's important to get your leadership in the room so they can hear it directly from the surveyors, and in addition to that, have an important dialogue about how seriously you're taking those findings and what you plan to do to correct the deficiencies that were found. Listen carefully. This is not a time for you to refute findings or to engage in a negotiation. This is a time for you to hear the perspective of regulators, to thank them for their work, and to ensure them that you will do your best to make the improvements in the areas where they found you to be deficient. If the survey has been well managed, nothing should surprise you at that exit conference. On slide 52, we outline the next steps when the regulators and surveyors leave, and that is beginning your regulatory plan of corrections. In fact, you should, however, begin that plan while the regulators are still on site. As soon as a deficiency is found and is suspected, begin developing a plan to show what you're going to do to ensure that you're able to respond effectively to that deficient finding. Don't wait to receive the report. Typically, you'll have only 10 days from receipt of a report to respond, so you need to get to work as soon as that deficiency is found. Those regulatory plans of corrections need to contain certain elements. You need to know what has been done to address the deficiency, what further steps are going to be taken, on what date will those steps be completed, how you'll be able to monitor the implementation of the plan, and who is responsible for the implementation of the plan. Answering those 5 questions will ensure that you have a very complete and thorough plan to respond to your survey findings. On slide 53, we list some attributes of a well-managed regulatory visit. Those include leadership being aware of the upcoming visit and understanding the organization's risk areas, that efforts to address those risk areas were underway and could be described, that regulator arrival and opening meeting goes very smoothly, that escorts play their role competently, that daily debriefs identify possible resolution opportunities, that there are no surprises in the closing meeting, and that a plan of correction is in process before the regulator's report arrives. On slide 54, we ask you to move beyond the regulatory readiness to really trying to focus on ongoing safety improvement. On slide 55, we list important steps that can be taken for regulatory readiness. Organizations need a defined process to prepare for upcoming surveys. You don't need to know the survey date. You just need to know what they're going to be looking at and what your organization is doing to respond to those challenges. The most important role for you as a patient safety leader, though, is in the second bullet, shifting the mindset. It is not about being ready for the next survey. It is about being ready for the next patient. If you focus on patients and not specifics of regulatory visits, in fact, you will be able to change the mindset of your entire organization to one which focuses in on patients and not particular aspects of any survey. You need to identify priority issues, plan to address them, and make sure that you measure your progress continually. It's not about being ready for the survey. It's about understanding what surveyors will be looking at and ensuring that your organization is working on those issues and has the data to show that you're taking it seriously. One example of a way to do this is establishing an Excellence Everyday Coordinating Committee. This is shifting from let's be ready and ramp up for the next survey to let's make sure that we're being excellent every single day. That's a vehicle that can allow your organization to assess its risks against various standards that surveyors will come and look at you against. The aim of such a group is to be in a constant state of readiness for demonstrating compliances with standards set forth by accrediting agencies such as the Joint Commission, Department of Public Health, the Magnet Survey Process, and the Center for Medicare and Medicaid Services. One simple model is to ensure that you have a group of champions throughout your organization and on every single patient care unit who have 3 major roles: to educate, to teach, to communicate, to share, and to motivate, to inspire those who work there to not only be ready for a survey, but in fact be proud of the work that they're doing and be ready to share their pride with those who are evaluating them. On slide 56, you see one example of the type of data that such a committee can look at. This shows you compliance with the Universal Protocol through observations done in a number of areas in an organization. You can see that specific elements of the Universal Protocol are all observed, and compliance with that is carefully tracked over time. There is modest but important continuous improvement there, which can make all the difference when a surveyor walks through the door. You can tell them that you've been working on this issue, you take it seriously, and you have the data to show for it. On slide 57, you see a general quality and survey framework that you can use to ensure that you're managing the survey process well. That includes making sure that those in your organization understand that, as the IOM told us, there are 6 aims to ensure that we're providing high quality. They include being safe and effective, being efficient and timely, and being patient-centered and equitable. You should, through your Excellence Everyday Committee or other vehicle, be able to show that you're undergoing a process of continuous improvement to ensure that you're getting better every single day. Slide 58 illustrates the fact that sometimes things don't go particularly as you would hope. In fact, we had a survey here late in 2006 at the Massachusetts General Hospital which found a number of defects in the way that we were providing care. A report in the Boston Globe was one which many could view as potentially devastating for an organization, but we're asking you as a leader in patient safety not to have the usual recoil and rebut response, but instead to capitalize on such a crisis. On slide 59, we show an example of such a response. Needless to say, those who are working very hard in healthcare every day, hearing that they're not quite measuring up is devastating. But rather than let the popular press tell that story, we felt it was important for us to tell this story. And so we put our Joint Commission findings out there for all to read on the web and made that accessible to our patients, to patients' families, and to our own healthcare staff. On slide 60, you can see that we went through each of the areas where the Joint Commission found us to need to improve and said, what did the Joint Commission find, explained why it was important, what we were doing about it, and where we're at now. By putting that out there in plain language, we ensured that the public knew that we took this seriously, that we were going to work on it, and that they could hold us accountable. In addition, this response gave our staff an opportunity to take pride in their work and to ensure that we're all in this together. Rather than be hostage to events, we decided to capitalize them and let folks know that we wanted to be transparent both within our organization and with the external public, and that we were going to all work together on improving patient safety. On slide 61, we leave you with some final thoughts. The first is to recognize that when it comes to making sure that you are ready to meet your compliance and regulatory challenges, that you focus not just on individuals being ready such as yourself, but that you build teams. B teams with A systems always beat A teams with B systems. As they would say, it's the system, stupid. You need to have a system of regulatory readiness and excellence every day in place. Because we need an A team, not just A individuals who are terrifically prepared, but we need to put them together into functioning teams and provide them with the systems to improve. The second piece of general advice is that in the end it's not the seed, it's the soil. That whether or not you're going to be successful in the regulatory world depends not just on having great interventions or seeds, but depends on the culture that you have within your organization. A culture of openness, a culture that will help capitalize on a crisis, a culture that ensures that we are trying to be excellent every day, and a culture which focuses on safety as a prime means of the way that we provide high-quality care will allow you to have interventions that are going to work to ensure that you'll do well with your regulatory mandates. Innovations are terrific, but you need to spread them throughout the organization and a compatible culture allows you to do that. In many ways, we all know that the political challenges are much more difficult than the technical ones. It's not about having the great new electronic system to ensure medication safety, but it's to make sure that people will use that system to embrace it and not develop workarounds. That's a function of culture. And in many ways, people would argue that the Toyota production system got that right. We need to get our leadership on board to make them part of this team, and then to spread that to our professionals and to all our staff. And finally, rely on both data and anecdotes. We need to have great data to ensure that we're measuring ourselves and can tell our story in a quantitative fashion. But to really capture the imagination of our colleagues and of those who come in to evaluate us, you need to tell those important patient stories. In fact, many organizations have actually brought patients into the survey process to meet with surveyors and regulators to help allow them to tell their story about the care they received in that organization. By putting those together, you can in fact compel wonderful action. Never waste a good crisis, never worry alone, and good luck. Thank you for your participation in this course, and thank you for your work on patient safety on behalf of all Americans.